Thank you again for the invitation to present this topic at the meeting. I don't have any conflicts to disclose. So this is the agenda of the talk today. I will briefly discuss the history of transplant survivorship guidelines and then discuss how we updated the guidelines this time. Then we will also talk about the summary of major changes and updates that we made in this new version, and then talk about the next steps that we are planning. So first, talking about the previous versions of the guidelines. So the first guidelines were published in 2006. This was a publication in ASTCT, in TCT journal, and it was a collaboration between CIBMTR, ASBMT, and EBMT at that time. Subsequently, the guidelines were revised in 2012, and at that time, additional societies had also been involved, including APBMT, ANZTCT, EMBMT, and SBTMO. There were several strengths of the previous versions of the guidelines. There was one table that was specifically very comprehensive and included compact and high yield recommendations for major organ systems. And it was ensured to be feasible across multiple medical systems. There was also additional background provided in the guidelines in a narrative format. As I mentioned, that there were several medical societies that were involved in this effort. So there were contributions and agreements from all of those societies. And it is considered a standard of care, and it serves as a foundation and follow-up plan for most of the survivors to this date. And as I mentioned, it was considered standard of care at that time. But it is important to know that a lot has changed since 2012 when the last guidelines were published. As we all know that now annual number of transplant are continuously increasing. So this just shows the number of transplants reported by the CIBMTR, number of allo and auto transplants. And I have highlighted the 2012 year by a red line. And as you can see, the numbers are continuously increasing even beyond that. Additionally, we have changed the way we practice transplant. So specifically with regards to patient age. So on the chart on the left, you can see that the percentage of patients receiving transplant after ages of 65 has significantly increased over the course. And additionally, the donor types use is also changing over time. So the figure on the right shows that the percentage of haploidentical donor transplant is also significantly increased over time. Additionally, we are offering new treatment modalities to our patient population. So this is the chimeric antigen receptor T cell infusions in the US reported to the CIBMTR. And as you can see, since 2016, the numbers have significantly increased, and they continue to go up with increasing indications for CAR T cell therapy. Additionally, we are also doing better at curing patients, and patients are surviving long term. So this paper is from Dr. Navneet Majhel's, and it shows the projected number of survivors of transplant over the time. And on the left, it shows that it is estimated by 2030 there will be 500,000 transplant survivors of all ages. And the graph on the right shows that there will be almost 50,000 survivors of just pediatric population transplant by year 2030 as well. As we continue to do better with treating our patients, we are also interested in sharing our information, how the patients are doing long term. So this is just a search from PubMed on transplant and late effects. And as you can see, there were not many publications before the year 2012, which is highlighted by the red arrow. But the number of publications have again significantly increased since 2012. And that is also one of the reasons we wanted to make sure we are capturing additional new data that might be available in while updating the guidelines. So with those goals in mind, we pursued this updating the guideline. So this time we took a slightly different approach. We wanted to use this NCCN-like approach. There is a NCCN guideline that are widely used in for different cancer populations. And for those guidelines, they ask all the group members to vote on one if they agree with the recommendation, and if not, what would they suggest as a change. And this is how the strength of each recommendation is measured with grade 1, 2A, 2B, and 3. So we used that format, and we went through the several phases of guideline development and revision, as you can see here on the right. And we are finally at the last stage, which is the dissemination of the guidelines. This was again a very large collaborative effort with 31 members representing 11 international societies that include adult, pediatric, and societies and patient advocates as well, as listed here. And these are the names of all the members that participated in this effort. Dr. Seth Rotz and Dr. Rachel Phelan and myself, we took the lead on this effort, and we were supported by senior mentors such as Dr. Betty Hamilton, Dr. Scott Baker, Dr. Christy Duncan, and Dr. Navneet Majhel. It was a co-publication between TCT Journal and EBMT Journal back in February. So I would definitely recommend you to review this publication. Um, I will highlight in next few slides what are the major changes in this guidelines. This is not by no means going to be a comprehensive review because it is impossible to go through this entire publication in 25 minutes. But I'm hoping that at least if I can orient you, you can go and review the article and it will be more useful. So in terms of changes in the manuscript, so we added a new hematopoietic complication section, which wasn't available before. We did significant expansion of psychosocial adjustment, cognitive dysfunction, and quality of life recommendations. We also updated vaccine guidelines since there is a lot that has changed since 2012. We also added information on return to work and school and other transition resource. We also provided additional recommendation on subsequent malignant neoplasm screening. And then lastly, we included special populations such as or patients undergoing transplant for autoimmune diseases, hemoglobinopathies, bone marrow failures, inborn error of immunity, enzymopathies, metabolic disorder, and myeloma and amyloid diseases, since these patients have their unique needs that we need to address through the guidelines. And additionally, we also highlighted specific considerations for patients who are infants or adolescent and young adults and older adults. So now I'm going to show you some major changes in how we develop those. So this is just a comparison of the topics that were included in 2012 versus 2023. So there are 16 major organ systems included and 20 total topics. Those highlighted in red were not included in the previous version, and the ones in blue are the ones that we have updated. So I'll share some of the examples in next few slides. The There were 11 summary tables total for each organ system, and it includes recommendations, evidence grade, references, and comments. We also have several supplemental tables at the end for additional details. And then there are also several appendices for resources for patients and then other stakeholders, and also resources for return to work or school. And I will talk about each of these organ systems one by one. So first, I'll talk about the hematopoietic system. Um, as I mentioned, it's a new section, and we specifically addressed autoimmune cytopenia after transplant, clonal hematopoiesis after transplant, iron overload, venous thromboembolism, and also specifically monitoring of chimerism for certain populations. So I will not go through this table in entirety, but just wanted to highlight some of the things that we tried to capture here. So we specifically made a recommendation regarding chimerism assessment for patients undergoing transplant for hemoglobinopathy. We also made several recommendations regarding how iron overload should be monitored after transplant. And then also additional recommendations about venous thromboembolism prophylaxis, specifically considering higher risk in patients with multiple myeloma. We also added additional information on patients with inherited bone marrow failures, as they need specific follow-up as reported by previous publications through PTCTC. And then lastly, we included a supplemental table which shows the specific details such as late complications, the risk factors, um, what to do for routine patient populations, and what to do for specific special populations. And for each of the tables, there are publication or key publications that are cited at the bottom, so people can look at them if they need more information. Next, in terms of immunity and infection, we made recommendations regarding vaccination after transplant. We also updated the table at the end for in the appendices regarding the vaccination guidelines. This is a constantly evolving topic, especially this publication was being worked on during COVID pandemic. So we could not make strong recommendations regarding some of those things. However, as we know that this is constantly new vaccinations are becoming available. So there is definitely a need to continue and revise this recommendations over time. And we specifically addressed concerns for patients with inborn error of immunity and how we should be monitoring those patients. This again shows some specific special population recommendations for this inborn error of immunity and multiple myeloma. And again, this is the supplemental table for immunity and infection, just in the similar format as I showed before. For cognitive, psychosocial, and quality of life complications, we highlighted the need for audiologic evaluation for certain population. We also highlighted the need for assessment of neurocognitive assessments especially for pediatric populations, and monitoring developmental milestones, and then recommended formal neuropsychological testing for certain populations. And we also included certain recommendations such as comprehensive geriatric assessment for older adults, as that has become really important for this geriatric population. We also highlighted the need for symptom assessment and monitoring of medication adherence, and then also assessment of lifestyle. We are also showing recommendations regarding the screening for mental health with standardized questionnaire, and also addressing the distress and psychological issues related to spouse or caregivers. And then there are several resources at the end for patients that could be shared by clinicians when they are seeing them, so that they can get additional support as needed. Uh, we also address the needs that are unique for adolescent and young adult population, because they are going through several transitions over the course of their life, and they need to be monitored closely. Otherwise, there is a high risk of loss to follow up. So we uh, had a special section on AYA, and also included certain references for the need for the special monitoring of this population. There is a increasing literature on subsequent neoplasm after transplant. Specifically, this paper just came out in 2020 that looked at subsequent neoplasms after non-malignant transplant. So that was a seminal paper from CIBMTR that had to be included in this effort. However, there is a lot of information that is still coming out even after the publication of our guidelines. So it just shows you that there is ongoing need to revise this guidelines, especially with the information that is coming out on subsequent neoplasm after CAR T cell therapy. We try to ensure that in this section, that if the risk is not modified by transplant history, the screening should be done according to what is recommended by a local region and um, pertinent to their underlying medical, family, and genetic history. But patients should be counseled about SMN risk, and they should be encouraged to have recommended screening if possible. And high-risk behaviors and unhealthy diet should be avoided. So this is the recommendation regarding the risk of treatment-related myeloid neoplasm, how those patients should be followed after transplant. We also have recommendations regarding breast cancer screening for female recipients who received chest-directed radiation or TBI. And then we also have new recommendations regarding colorectal cancer screening with either colonoscopy or multi-target stool DNA testing. Both breast cancer screening and colorectal screening recommendations were revised in last decade, so it was very important to include them in this effort. So what are the next steps of after these guidelines have been published? So as I mentioned, that manuscript publication was just the first goal. There have been several efforts to disseminate this information through various platforms, such as this meeting is one of them. NMDP is very interested in collaborating with us to develop, update their website, also have some webinars through them. We have been presenting at several conferences and other societies, small meetings. And then we are also in process of updating the ASTCT website and mobile app. So this information will be very handy for clinicians when they are seeing patients. And then lastly, we still have a couple of outstanding things to address. One of them is how to translate this information into different languages, so it can be available across the world. And then how can we make sure that the guidelines are being updated on a regular basis, so that there is some sort of formal mechanism that we can put in place for regular review. There is also a lot of need to understand if the guidelines are being followed by both patients and clinicians, or if there are certain barriers to following these guidelines. We are currently working on a study to understand adherence to this transplant guidelines. This is just a snapshot of the work that we are doing at our local center. in Seattle, but we are also looking at adherence and across the country in the US. And hopefully in future we can also look at other countries to make sure we address barriers for guidelines adherence. As I mentioned, we need to have ongoing revision of these guidelines, but also importantly, we need to include other key stakeholders such as nurses, social worker, and other subspecialists who are experts in these topics. And we need to decide how these guidelines will look like, whether we will be waiting another 10 years before we publish it, or it will be done at more frequent time intervals. There is a lot we still don't know about the future of late effects research, specifically how the genetics play a role in this, what is the role of artificial intelligence or machine learning. We also need additional data, including systematic review. And again, as I mentioned, we continue to have newer therapies available for our patient populations. There is also a lot of interest in incorporation of patient-reported outcomes data, and how patients are feeling about certain late effects, uh, how to combine data between different registries to increase our understanding on certain complications. And then again, other technologies for continued engagement of patients through transition so they don't get lost to follow. So a lot to do and we are excited to work on these efforts in future as well. Again, this work couldn't have been possible without the help of these collaborators and colleagues. I wanted to acknowledge them once again, and then I will be happy to take any questions at the end. Thank you.